Okay, welcome everyone. Good morning, good afternoon. My name is Christopher Lindahl. I'm the Deputy Director for Knowledge Management, Learning, and Strategic Communications for Momentum Integrated Health Resilience. And I'm really happy to be facilitating the webinar that we're doing today on the Humanitarian Development Nexus for Health. Before I jump into the content and get our speakers going, I just wanted to run through a couple of housekeeping notes. There is English and French interpretation available for today's webinar. At the bottom of your screen, you'll see that little globe icon, and you can pick your language there. So if you want to be listening in French, you can select French or stay on the English channel. Today's webinar will also be recorded, again, both with English and French. And both the slides and those recordings will be available on the Momentum website, probably next week. If you'd like, we'll have some time at the end for Q&A. So please, throughout, you can go ahead and put any questions you have into the chat box and we'll address them at the end. So for our session today, we're going to be talking about the Humanitarian Development Nexus for Health, particularly focusing on two case studies from South Sudan and Mali. And we'll start with an overview and some of the high-level case study findings, and that will be from Paul Spiegel and Amani Kadur. We'll then do a Mali deep dive and a South Sudan deep dive, where each of them will get into some of the programmatic implications of the findings and kind of some of the more specifics related to those case studies. And you'll hear that from the chiefs of party for MIHR in those countries. And then, as I mentioned, we should have 10 to 15 minutes at the end for some Q&A and discussion. So with that, let's get into it. And I'd first like to welcome Dr. Paul Spiegel to provide some opening comments on the case studies that they worked on. So Paul Spiegel is a physician and epidemiologist and is the director of the Johns Hopkins Center for Humanitarian Health and distinguished professor of practice in the Department of International Health at Johns Hopkins Bloomberg School of Public Health. Before he was at Hopkins, Dr. Spiegel was the Deputy Director of Program Management and Support and the Chief of Public Health at the United Nations High Commissioner for Refugees. Paul, over to you.
Great. Excuse me. Great. Thank you, Chris. And good morning, afternoon, evening, everyone. So welcome to the HDN webinar hosted by USAID-funded Momentum Integrated Health Resilience Project. I'll give just a very brief introduction of an overview of our HDN project, the research scope, and some context for today's discussion. So first, I'd like to define HDN, or the Humanitarian Development Nexus. This term refers to the intersection of humanitarian and development activities, and it's essential in planning and delivering services to crisis-affected populations. Our research approached the nexus primarily from a development perspective. That's quite important. So exploring how these activities intersect within this framework. However, we're also focused upon the humanitarian aspects, which were included through stakeholder feedback and across both sectors. So our research involved developing a framework for the Humanitarian Development Nexus, which Amani will show you shortly. We then undertook two case studies in South Sudan and Mali, which focused on the RMNCH, or the reproductive, maternal, and neonatal and child health. And although that was our key focal area, it was very clear from early on that the breadth of issues we encountered with the HDN often went well beyond health services, covering broader priorities in the crisis settings. So the research focused on all HDN activities in each country, not those specific to USAID operations or the Momentum MIR projects. Again, I think that's really important because this was not an evaluation, this was rather trying to understand HDN in a more holistic and comprehensive manner. And then finally, the research was conducted in specific geographical regions within Mali and South Sudan. And so these findings cannot be considered and should not be considered nationally representative. Due to the scope of the work, the peace aspect of what's often called the triple nexus, HDPN, or the Humanitarian Development Peace Nexus, was explicitly not explored deeply in these studies, but it does remain an important area for future research. So we hope that this contextual framing helps to clarify the scope of our study and thus our findings. Thanks for joining us, and we look forward to sharing insights and then contributing to advancing the HDN within the health sector response in humanitarian settings and development settings. Now, Amani, over to you, and you'll be presenting our findings.
Sure. I know, Chris, I think you had a few comments, but I'm happy to start.
I was just going to give a brief intro for you, actually, Amani. So, but thanks, Paul. Yeah. So just to introduce Amani, Amani is currently an associate faculty member and doctor of public health candidate at Johns Hopkins Bloomberg School of Public Health. She also serves as the director of the humanitarian NGO Syria Relief and Development. She's briefed the UN Security Council on more than one occasion and was previously awarded the Outstanding Leadership and Advocacy Award by the American Public Health Association. So thanks, Amani, and over to you.
Thanks, Chris, for having us, and thank you, Paul. Good morning, good afternoon to everyone. I'm going to pick up where Paul left off. I know one thing for certain today will happen by the end of my presentation, which is our wonderful translator will likely hate me, but I'm going to keep forgetting to speak slowly. So please, Chris, let me know. I wanted to start off also by thanking our research team. Some of them are here today, including Gabby Prager, Lauren Yan, Adama Yalkuye, and of course, thank you to the MER teams and teams in Mali and South Sudan, and of course, all of our key informants who generously gave us their time for this research. So picking up from Paul's introduction, I wanted to briefly showcase the HDN framework that guided this research. A large focus of the case studies was on the core pillars that you see here, especially financing, leadership and governance, and coordination, given how much these influence the Nexus. And this also draws from other frameworks you're likely familiar with, including the WHO health system building blocks. Next slide. So here's a brief overview of our methods. We developed two qualitative case studies, one in Mali, one in South Sudan, by carrying out both individual and group key informant interviews, along with a document review for each country. In South Sudan, we conducted 41 interviews in Juba and Bourtown, and in Mali, we conducted 48 interviews in Bamako capital and Gao. Some of the stakeholders we interviewed included Ministry of Health, UN agencies, clusters, local and international NGOs, and donors as well. Next slide, please. So I'll briefly discuss context before I dive in. Granted, this in no way captures all of the nuances. Contextually. In terms of South Sudan, this is a country that's been consistently ranked amongst the most fragile countries globally. Recurrent shocks and stresses, including flooding and displacement, infectious disease outbreak. Maternal and newborn mortality rates are the highest globally right now. Even before 2011, there was a marginalization of the population, with, I'd say, about 15% having access to healthcare at that time. And that fragility is carried over with less than half the population able to access healthcare today. And lastly, there are multiple sanctions imposed on different individuals, including from government, for issues related to corruption, human rights violations, and obstructions to the peace agreement. In terms of Mali, the political landscape and multiple coups have had an impact on the humanitarian situation. And I would say in the majority of our interviews, 2012 was often referenced as this major inflection point or trigger for the humanitarian crisis in the country. There's been a long history of overlapping mandates, so peace, humanitarian development, but also criticism that stabilization and counterterrorism efforts often overshadow or over-militarize the humanitarian imperative in Mali. Climate shocks have also had a tremendous impact, specifically on food security, and part of this is also due to the war in Ukraine, given Mali's reliance on food imports. And lastly, fragility in the northern and central regions have borne the brunt of violence and instability. And our case studies really zeroed in on interventions in these more fragile regions. Next slide. And now I'm just going to move on to some of our key findings in South Sudan. In terms of leadership of the health sector, both humanitarian and development assistance, this was predominantly managed by international actors, with the Ministry of Health often perceived as having symbolic authority. So as a consequence, there were parallel leadership structures in place. And much of this stems from limited investment in the health sector by the government. Over the past several years, it's fluctuated somewhere between 1% to 5% of government spending, with most being subsidized by international assistance. And although the health system is decentralized, I would say at least on paper, we found in our interviews that most of the decision making was really concentrated at that national or Juba level, with some of the concerns at the subnational level related to influence on decisions and prioritization of health services. Next slide. In terms of the health finding landscape, I would say this was and is extremely complex and probably one of the most significant factors that influence Nexus health implementation. On the development side, there were two major financing mechanisms, one being the Health Pooled Fund, or HPF, which covered about 8 states at the time of our visit. It's changed since then. And the World Bank, which covered 2 states. Most of the services covered under these 2 funds were quite similar to those covered by humanitarian actors, just over a longer period of time. And this is why in our report and the case studies, we actually refer to them as covering long-term humanitarian needs rather than being development oriented. And in 2022 to 2023, which was our period of research, there were some major drawdowns of HPF funding that impacted over 220 health facilities, primary healthcare clinics, units, hospitals. And although the plan was for the government to take over completely after this period, it did not. During this time as well, humanitarian funders, including, for example, the South Sudan Humanitarian Fund, were being drawn in to help cover some of these major gaps. So I would say rather than complementarity between these 2 types of assistance, both were actually quite similar. And following our research, actually, one of our recommendations was to consolidate all of the development funds. And in 2024, this actually did occur, where a new multi-donor trust fund managed by the World Bank was announced. Next slide. In terms of coordination, not surprisingly, what we found was that humanitarian coordination mechanisms were much more formalized through the cluster system, whereas development coordination was only encouraged since it wasn't technically mandated. At the national level, there were a few formal bodies that you see here on the slide that were in place, bringing together both humanitarian and development actors. One was the Partnership for Peace, Recovery and Resilience, PFPRR. I'm going to try to avoid acronyms today. But really, with some of these, there were 2 concerns. One was that these platforms were often so high level that they perpetuated the same top-down, internationally led approach, with local actors not sufficiently involved. And then 2, that some of these initiatives were so new that there really wasn't enough political will or buy-in yet. And then at the subnational level, decision-making power was raised, along with duplication as a concern with multiple actors involved at the same health facility at times, or overlap in terms of at the community level in terms of different health workers. And I know Dan is going to discuss the BOMA Health Initiative in particular, so I won't go too far into that. And then just lastly, there were some areas of opportunity we identified. So one was this need for explicit and transparent mapping of all efforts across humanitarian and development actors, operating both from an implementation standpoint and a financing standpoint. And then the second opportunity was really this feasibility of engaging with government health technocrats or counterparts, at Ministry of Health, for example, at the subnational level, since the indirect impact of sanctions on the health sector was really more palpable at the national level. And next slide. Thank you. And then one area of focus for us was on family planning within RMNCH. And Dan's, again, going to discuss this in detail, but I wanted to just briefly mention a few of our findings. What we found were some key differences in terms of buy-in for family planning by both humanitarian and development actors. These types of interventions were often considered to fit in more with a development mandate and essentially less prioritized across the Nexus. Long-term planning and funding was also needed to address some of the sociocultural and normative aspects, but this was, of course, extremely challenging to do since development funding was already shrinking during the same time period. And then next. And now I want to move on to some of our key findings in Mali. For Mali, I think I'm just going to jump straight into some of the examples of implementation, obviously bringing in some of those core pillars that we discussed from the start. One was this concept of an accordion model for interventions that came up specifically from UNFPA, where it had restructured and integrated humanitarian and development units. And the goal was really to maintain comprehensive services in areas where it was feasible. Remembering that Mali has a much longer development history before 2012, but then also this flexibility to respond to emergency needs by expanding teams, but essentially scaling down services. So this is an example of this would be implementing the MISP or the minimum initial service package, for reproductive health in some of these regions. And then this is likely more relevant for multi-mandate organizations that are delivering or supporting both humanitarian and development assistance. Next. And then I wanted to segue to some of the health financing examples that we charted with some of the actors that we know to be traditionally either humanitarian or development, but finding there was a much more flexible mandate in Mali. One was MDM, or Médecins du Monde, which had integrated humanitarian assistance from the humanitarian donor ECHO with funding from AFD, or the French Development Agency. And the development funds from AFD in particular were used to support governance structures at health facilities, along with reconstruction, particularly after the onset of the humanitarian crisis, since humanitarian funding in particular has restrictions on support for infrastructure. So really highlighting that complementarity between the types of funds. Unfortunately, this type of funding was stopped in 2022 because French development assistance was suspended in Mali. But this was just one of the examples that came up. Another example was from International Medical Corps, or IMC, for those of you that are familiar, which was implementing cost recovery programs in the north. There were some communities that received partial coverage and others that received entirely free services, specifically for antenatal and postnatal care. And some of the evaluations that we looked at for this program showed a few things. One was that coverage rates were actually very similar, and even in some cases higher for cost recovery, essentially suggesting that cost recovery could potentially be appropriate in certain regions, obviously depending on context. And then the last example I wanted to showcase was the World Bank's, obviously a traditional development donor and stakeholder, but its implementation of performance-based financing, with the World Bank obviously only operating where there's a formal government in place. This is obviously an issue in Mali where it's been interrupted quite a few times with some of the more recent coups. But part of the contingency planning for some of these scenarios was ensuring that supplies and payments, for example, were transferred in very large tranches, sometimes 6 months at a time, just expecting some of the restricted access that would be the case. And then there's a very important caveat to such financing, since there's quite a bit of evidence that this is less feasible in fragile settings, and also concerns around monitoring, oversight, compliance, given some of the limited access to the north for extended periods of time. Next. Another example I wanted to highlight is one that leverages an area-based approach, which I'm also going to discuss in the recommendations, which was implemented in Mopti, Ségou, Sikasso over a 5-year period. It was focused on health system strengthening, This was a sister USAID flagship project. So Kenya Nyata was actually implemented at the health facility level at multiple levels, so regional, district, health area, in terms of supporting governance structures and developing some of the clinical guidelines directly with the Ministry of Health, for example, for reproductive health services. And then Kenya Sinsiwale was implemented at the community level with two main components. So one was social and behavior change, specifically for reproductive health and family planning uptake. And then the second was establishing these, what were called solidarity-based funds, essentially some form, a precursor, I would say, to community health insurance. Next. And then before I summarize some of the key takeaways and recommendations, I wanted to just briefly touch on a few cross-cutting issues or themes in both case studies. This is by no means extensive. There are plenty, so we encourage you to read the case studies. But one was some of the silos in multi-mandate organizations. Again, these are organizations that have a humanitarian development and/or peace component, oftentimes stabilization as well. This will continue, some of these silos in these organizations will continue to limit the feasibility of implementation of the Nexus because there are just far too many differences in terms of programming and funding cycles, and obviously some other elements, for example, reporting requirements. And then localization was another recurrent theme. With the need to strengthen institutional capacity of local actors. And when I say local actors, I also mean local government, rather than just focusing on technical trainings. This was something that came up in multiple interviews. And then, of course, localization, obviously, we tied it in very closely with human resource implications, specifically for the local workforce, since both cases charted major challenges in recruitment, in retention, violence to healthcare workers. These are both extremely dangerous contexts, and really thinking about how healthcare workers and generally aid workers at large were protected, and also how healthcare workers were the first to respond in the event of an emergency, obviously at the community level, so those frontline responders, and then also necessary for the sustainability of health services in the long term. Next. And then finally, I just wanted to recap a few of our recommendations from the research. So these case studies really demonstrated that we need to find ways to nuance fragility while avoiding this whole country approach, and then assessing if the Nexus is feasible. So in both countries, there were pockets of fragility that would allow for very, very limited sustainable development. So this is why we really want to underscore the need for area-based approaches at the subnational level, and then leverage some of these aspects of decentralization of the health system, and interventions. And then this is why we've also conceptualized the Nexus and feasibility as more of a spectrum, I would say, where there are certain areas that are appropriate to implement medium or longer term interventions, so early recovery, development, relative to other more fragile regions. And then this spectrum approach could allow for a more differentiated approach or response according to fragility at subnational levels. And then we also recommend incorporating a health system strengthening approach in both humanitarian and development assistance. This was really important because there was still not, and generally in the literature as well, not collective buy-in that health system strengthening is as feasible in humanitarian or fragile settings. Oftentimes it's assigned or ascribed more as a development mandate. And then there also needs to be more alignment between humanitarian interventions and national development plans already in place. That's, of course, much easier said than done, since so much of the coordination and financing is happening in two separate streams. Between these forms of assistance. And then I'm going to leave it there because I know Aminata and Dan are actually going to highlight some of the community level examples of implementation and also preparedness and planning. So I'll hand it back to you, Chris. Thank you.
Great, thanks, Amani. And I know you couldn't go into all of the detail for all of those recommendations, but I do have a slide that we'll show at the very end, and we'll share some links to the actual case studies that Amani was referencing. We have a case study for South Sudan, a case study for Mali, and then a brief that summarizes them. So I'll put those links into the chat at the end today once I show that slide. So with that, I'd like to turn it over to Aminata Traore to go a little deeper into the Mali example. And so Aminata is a medical doctor with a master's degree in public health and over 25 years of experience in a variety of roles. Since 2020, she's been the chief of party for Momentum Integrated Health Resilience in Mali and previously supported Mali's COVID response, served as chief of party for USAID measure evaluation in Mali, worked on other donor-funded projects, and spent time working in the Mali Ministry of Health at the national and subnational levels. Aminata is going to talk today about the use of the ARCD Health Tool and transition plans in Mali. Aminata, over to you.
Thank you, Chris. Good morning, good afternoon, everyone. I have a pleasure to share with you our work on the ARCD assessments and how MIHR Mali address some of the findings of ARCD assessments. ARCD assessments ARCD is a tool for analysis community resilience to disaster. And these tools has been adapted to health. And in Mali, these analyses were carried out in MIHR intervention area between January and February 2023. And the objectives of this assessment was to adapt MIHR interventions to the local context. And the ARCD assessment in Mali addressed three objectives. The first is the identification of the list of shocks and stresses. The second is the self-assessment of community resilience capacity, and the community engagement was the third objective, the community engagement for an active role in effort to strengthen health resilience. Slide, please. This slide this table presents the main shocks identified and the associated stresses. We identify a long list, but this shows the main. And for also we identify the consequences on the population and the impact of health. And for the Gao in Timbuktu, when we did the assessment, then the two main shocks were identified. One is the armed conflict with increase in violence, and the second was the flood. We noted also that the major impacts are in health. Malnutrition and the difficulties in accessing health services, and these difficulties to access health services also impact the delay of giving care to some vulnerable population, and also increase maternal and infant mortality, and some spread also of epidemics. We also would like to mention that one of also the major impacts is the mental health. And we saw that we have no action also in MIHR to address the mental health. But we did some collaboration with some partners and to identify the way to address that. There were also on the assessment, we identified that some existing mechanisms, such as the existing mechanisms, such as at the regional level, the community health workers program, and also the crisis and disaster management committees were existing, and collaboration framework also were between the government and the technical and financial partners to respond to health emergencies. Also was in those mechanisms were in place for the clusters. Slide, please. Following the identification of the list of the stress, the shocks and stresses, MIHR collaborated with stakeholders in Gao in Timbuktu to reinforce some mechanisms and also set up some new mechanisms. We work with them to establish a community-based, to reinforce the community-based surveillance. And also we support the establishment of the community early warning and emergency responses, and also development of health facility emergency preparedness response plan. Some initiatives from MIHR also were to develop service continuity plan at all health area involving community stakeholders and also community health facilities. And some community health tools as the assessment and matrix and tools for community health program also was the kind of tools that we supported to set up at the community health center. We also the red approach, as this approach initially was developed by the WHO, UNICEF, with partnership with Gavi Alliance. We also integrated resilience aspects on these tools and support the health facility to develop the red micro plan at the health facility level, and the implementation also of community card score. This also was something in Mali, but not in the Gao and Timbuktu health zone. Slide, please. This slide just to contextualize before the talking about the transition plan. When MIHR started, many areas of MIHR intervention zone were still deemed free healthcare due to the non-functionality of community health association. Also, the cost recovery model where the SESCOM is able to sustain itself were not functioning, and this cost recovery system model includes staff coverage system and also health fee collected from the community health association is used to pay staff salary and also some fee for the health community center. How to end this free care? By MHR strategy, where to strengthen the capacity of providers and community stakeholders, ensure that community health center can operate without significant support from partners, development or humanitarian partners. Slide, please. The feasibility of the transition is depending of the ability of community health association to help those health costs, to cover those health costs for community given their role. The MHR project has incorporated various health system strengthening activities across communities, health workers, government counterparties, and also private sector. Those activities include the strengthening of community health association in local governance, because the local governance will help them to manage and to know their role and responsibility related to the management of community health association, and to also facilitate the recovery of costs at the health facility level. We did some activities like as a revitalization of community health association, recruitment of quality health workers, and for that we did MOU with them, and to make gradually withdrawal of MHR on this MOU. And also we work to strengthen the capacity of health providers in MNCH, such as prevention of maternal and newborn death, and active management of the third stage of labor, and focus antenatal care, the implementation also of maternal and perinatal surveillance, and integration of pediatric leave audits, nutrition, training on nutrition, reproductive health, and family planning and vaccination. Our approach also on quality improvements at the health facility level also help to recover more costs, because the population starting use the health facility, community health facility, and this health facility recover more costs to make able to support the salary of quality staff. And we put in place also the committee, the revitalize the joint community between mayor and community health association, and giving them each 5 engagements for financing community health centers, and we follow with them those commitments. The implementation of also the community family model approach. Also, this model approach family adopt behavior that are that can improve the use of health services, and also those families serve as really to raise awareness among other families. The Village Solidarity Fund, this also was the model as a fundraising at the community level to support some logistic for the reference of emergencies from the SESCOM to the SESREF, and from the village to the community health centers. And this also combined the training of community health workers and a nutrition group. We all those together will help the community health association to be independent from some direct support from the partners. And to date, on our implementation zone, we have 38 community health facilities that can recover costs at the health facility to support the management of community health centers. Over to you, Chris. Thank you.
Great, thank you, Aminata. Thanks for that. I'd like now to pass on to Dan Wendo to talk about integration of family planning and maternal newborn child health at the community level during shocks in South Sudan. Dan is a physician with over 40 years of experience in designing, leading, guiding, managing, and evaluating integrated health programs in several countries in East Africa. Since May 2021, he has been the chief of party for Momentum Integrated Health Resilience in South Sudan. Prior to joining MIHR, he served as chief of party for USAID projects in Kenya and Malawi, and spent time as a public health service director for several Kenyan districts and urban areas. Dan, over to you.
Thank you very much, Chris, and good morning, good afternoon, those who are on the call. I want to start by indicating that in South Sudan, when the Momentum Integrated Health Resilience started in 2021, we took time to do some assessments in order to identify what the major shocks are, so that we could then design programs that respond to the stresses and shocks that we have. So we did the baseline resilience assessment, which was basically a desk review and some focus group discussions. And we also did fragility to crisis, F2C. And then later on, we did also ACD. Now, the major shocks that were identified were basically flooding. And as you know, River Nile passes through our country. So we tend to have flooding. In fact, this year we have massive flooding with over 1.5 million affected, for example, this year. So over the years, that has been a major concern. The other major concern, which was identified as a shock or stress, is intercommunal violence. We've had situations where communities either fight over or grazing pastures or cattle rustling, and it really uproots communities. Communities get displaced into internally displaced communities. So those were the major ones. The other shocks that were identified were disease outbreaks and, of course, economic degradation that has taken place. But the major ones being flooding and intercommunal violence. So when the flooding and intercommunal violence occur, communities get displaced to camps, and facilities are looted. For example, they get looted and even completely dismembered. The health facilities get closed for quite a number of months. And of course, health workers are forced to leave. We also had a situation where violence had been meted on the health service providers. We did social norms assessment at the beginning of the program also to identify the general perception of the population on family planning, what the family size, what was known on menstrual hygiene, and the general expectations of the communities. It was important to know those so that when we design the family planning, reproductive health, and child health programs, it would be so that it should be responding we are answering the questions that are persistent in the community. Yeah. So when there are heavy displacements Of course, the access to services is completely reduced, or more deliveries take place in the communities. And of course, disease outbreaks also do occur in the camps where communities have been displaced to. Next slide. So when there's massive displacement of people, we work with humanitarian agencies because they have more mandate to ensure that there's livelihood, that the people are placed in those internally displaced camps. Yeah, but where people are not being or displaced heavily, or we had to get out of our way to work with communities to identify some of the enabling or activities that would allow access to family planning, reproductive health, and maternal and child health services. So we engage with the leaders of the communities, or we also do communication on on risks that do occur to communities, risks related to maternal health, reproductive health, and also child health. And we started discussing with the communities the issues of developing emergency planning, response planning, and also identifying how else themselves they perceive shocks and crises and what they could do. We identified importantly that the community health workers, which are called BOMA health workers, are very important community members that could enable services to continue within the communities or wherever they are displaced, or if there's flooding and communities are cut off, we would ensure that they continue providing services. So we integrated our program with another USAID program, Global Supply Chain. We also work closely with UNFPA and also the Ministry of Health to ensure that the health facilities are prepositioned with the commodities, and also that our community health workers, BOMA health workers, also have enough stocks of the reproductive health commodities that they would use wherever they may be displaced. And our program officers also continuously monitor the level of stocks in the nearby facilities and also the stocks, commodities that are with our BOMA health workers in the field. Then in order to create demand for the services that we'll be offering, because even if people are displaced, there could be demand. Yeah, so we worked with another USAID funded program called Breakthrough Action, and developed messages, which were pictorial messages, and some were also electronic messages. And the picture you see in the third column there, or together for each other, was developed as a theme that for all the social behavior change activities, or we say that we need to work together for each other to identify the health needs of every individual in the community. And the BOMA health workers were educated or mentored to be able to participate in male engagement activities, and also to enable them to be able to visit households to (15 to 18 months). We also worked with some experts to develop a social media approach and a platform that would be using Facebook and WhatsApp, and it's open to people to read or to access information on how to look after themselves and what to do or when they when they're in need for services that are affecting their reproductive health needs. So some of the preparations that we did for the service delivery or after the community sensitization is that we stationed specially trained or nurse midwives in nearby health facilities, not only to provide family planning and MNH services, but to also be a referral point for the community health workers if they need support or if they need mentoring. And we also trained the Boma health workers, the community health workers, to be able to distribute contraceptive methods that have been approved to their level. And the program also enabled self-care in the cyanopress or DMP or subcutaneous, where the Boma workers were trained to provide that injection, and they were also trained on how to train the members of the community if they want to go into self-care. So self-care is a package that has picked up in the counties where we work. I want to add that the Boma health workers not only do family planning, but they also help identify mothers that are expectant and refer them appropriately, but they also encourage immunization, the children for immunization, and they have also been trained to treat common childhood illnesses in integrated childhood case management at the community level. Next. So in this particular slide, it's just talking of some of the community engagements. I want to just focus on the fourth slide or the main slide, that we realize that it's very important to identify existing community structures like the women associations or the women groups, the youth groups, the peer networks, or community organizations and faith organizations, because these are the groups that are existing. Even when communities are displaced into internally displaced camps, they will still be there. And they are important individuals or groups that will ensure that there is everybody knows where to get health care if they need. Next. In this particular slide, we are just indicating some of the what we have reaped by the use of our Boma health workers. The green bars indicate the use of DMPA sub-Q self-injection at the facility level, while the red are the use of the same DMPA self-injection in the communities supported by the Boma health workers. So it really shows that investing in the Boma health workers, community workers, and community would be a very important gain in ensuring that in the crisis, the services will still be available for people in the communities. Yeah, and next. Lastly, we have had some lessons that we have learned. One of them is that use of the existing structures, leadership structures in the community is very important, particularly ensures resilience and enables ownership. And two, that the mapping exercise that we did enabled us to identify what crises are and also identify the existing skills and also existing community leadership that we can use. And then also the going down that the use of Boma health workers are community-owned resource people that understand communities, and it really prevents service interruptions at the community level. And it is important that whenever we do plan, we should have resilience in mind, so that the sustainability and the continuation of the services are borne in mind and can continue. We therefore just say some few takeaways and recommendations that in working in a fragile setup, we have to consider working with the local, working with local communities, both in planning, preparation, and implementation, so that they own it. Whether they are displaced, they still own it. And that we realize that when we develop emergency preparedness and response plans, it was very useful, because whenever a crisis did occur, communities were the first to come and say that let's move with our medicines from the community to a place where we are going for where we are going to be displaced. Yeah, so we would always say that training is a very important thing. It is it has to continue. We have to continue mentoring our service providers, stockpiling with medical commodities. It's very important. So having resilience lens in whatever we do can help improve the utilization of health services in the communities. Thank you very much. Chris, back to you.
Great. Thank you, Dan. We have not too much time left, but I did see one question in about South Sudan. So Dan, maybe I will give this question to you, and then I'll put some links in the chat while you're talking to some of the resources that where you can find a lot more information about this, these case studies. So we have a question that says, in the context of South Sudan, how have influxes of returning South Sudanese from neighboring countries impacted the existence of shocks and stresses in South Sudan, and how can humanitarian actors coordinate with the work when you have these influxes of returnees?
Okay, thank you very much, Chris. I want to cite the example of one of our counties called Kajokeji. Kajokeji is nearing Uganda. And there was a time when, most of the communities were displaced into IDPs in Uganda. When things cooled down, they came back. And when they came back, we coordinated with the humanitarian implementing agencies on the ground, and we as development partners, and we were able to ensure that the services were restarted in the health facilities, or facilities were well stocked with commodities, and we continued monitoring the environment. Then 2 years ago, again, some shocks did occur, and they went back again into neighboring country. And so it's been going on and on. I want to add that South Sudan has had a lot of chronic fragility. So the issue is to be open and be on the lookout for them to come and also inform the other implementers. Thank you.
Great, thanks, Dan. And I think with that, just given the time, we've got to wrap up here. So thanks everybody for your attendance. Thanks to Aminata, Dan, Paul, and Amani for their presentations. As I mentioned, I put into the chat 4 links, to some of the some of the resources where you can go and find a lot more information. We only were able to scratch the surface on some of these, so you can go and get more information there. So thanks again. Special thank you to our interpretation team for the translation. I hope we didn't go too fast for any of them. So again, thanks everybody. Have a great rest of the day. The recording of this will be posted on the Momentum website in about a week. Thank you.
Thank you. Bye.
Thank you.